pulmonology all through the last 6 years. She did a lot of efforts, a lot of participations all through the last years, and I am so happy to be with us. And this year, I think that will be in a virtual conference in October, inshallah. My presentation is today is asthma controller in children below 5 years, clinical tips for ongoing home management. And I will start immediately in a very short way to overview the problem of asthma definition and the dilemma of asthma diagnosis, especially below the age of 5 years. And then to give a short note about the mechanism of action or the anti-inflammatory effect of ICS, what is the ideal ICS and the mode of administration, and the GINA Update 2020 recommendation for management of asthma with COVID-19 pandemic. And the last point is to discuss the nebulizers and infection transmission risk. And this is part of the presentation. I think that Dr. Malcolm, before he give us a very good idea about the aerosol generating procedures. Starting by asthma definition, for sure that the British and Scottish update, Thoracic Society update guidelines reported a very important sentences that they said or reported that it is impossible to make an evidence-based recommendations on how to make a diagnosis of asthma, especially in children, especially below the age of 5 years. And the GINA Update 2020, the asthma definition here, asthma is a heterogeneous disease, usually characterized by chronic airway inflammation. And actually, chronic airway inflammation is not just pathognomonic for asthma. We have a very long list of diseases like chronic obstructive pulmonary diseases, bronchopulmonary dysplasia, cystic fibrosis, primary ciliary dyskinesia, protracted bacterial bronchitis, eosinophilic lung disease, bronchiectasis, and we have childhood interstitial lung diseases, and so bronchiolitis obliterans. All of these diseases are associated with chronic airway inflammation. And even the GINA Update 2020 reported or said that even chronic airway inflammation is not an essential feature for diagnosis of asthma. And asthma, by definition, we have symptomatology which are very important: wheezes, cough, shortness of breath, and chest tightness, which vary over time. And the main problem here is how to confirm the variable expiratory airflow limitation. And that's why in children, we have diagnosis by two ways. First is by history taking, clinical examination, and this is the most important issues for most of the pediatricians, in which we have wheeze, shortness of breath, and chest tightness and cough. And then how to make the criteria of, how to make the criteria of diagnosis of asthma, especially in children. First is that we don't rely on only in one symptom. We are in need for more than one symptom in order to consider the diagnosis of asthma, like wheeze and cough, wheeze and chest tightness, and something like that. And then what is very important is the variability of the frequency and severity of manifestations over time. Asthma is not a monotonous disease by any way. And the third issues is that also variability of the severity of manifestations even within the same day. So we get variation and worsening of symptoms during night and early morning compared to the other day. Also, we have variability of the triggering factors for asthma presentations. For example, exposure to allergens, exposure to cold air, after exercise, after laughing. And so we have different provoking or variable provoking factors. And the last point is that symptoms often appear or worsen with viral infection. However, by this, simply, you can suggest what are the criteria you are selecting in order to get the diagnosis. This is the subjective way or the history and the clinical examination. But in order to confirm asthma diagnosis, you are in need to do something. two points. The first one is to justify that you have an airflow limitation, and this is measured by a reduction of the forced expiratory volume in 1 second over forced vital capacity below 0.9 or 90%, or just decrease in forced expiratory volume in 1 second. However, this is not enough because it is just proving that you have an airflow limitation or obstructive airway disease, and in which we have a very long list of differential diagnoses. But the very important issues is that you should prove or confirm the presence of the variable airflow limitation. How to confirm a variable airflow limitation? So by one or more of the following testing, like positive documentation of bronchial reversibility. And this is very important because this is one of the ATS guidelines for diagnosis of asthma by increasing in the forced expiratory volume in 1 second by more than 12% after 15 minutes from 2 puffs of Ventolin. Or you are doing or measuring excessive variability in the daily peak expiratory flow rate over 2 weeks, and if you have an average daily diurnal variation of variability more than 13%, this is documenting that you have variable airflow limitation. Positive exercise challenging test also is one of the confirmatory tests. Positive bronchial challenging test, however, this is done usually in adolescents and adults, usually not yet done in pediatric age except for research. And the last point, excessive variation of lung functions between visits, and this is the least reliable test that you can consider. It has a good specificity but poor sensitivity. All of these tests that confirm airflow limitation or variable airflow limitation cannot be done by any way in children below the age of 5 years due to the incooperability of these kids or children to do pulmonary function testing. So you cannot by any way to confirm the diagnosis of bronchial asthma because of the limitation of all of these testing. Then we have an important question that, is there a standard definition for recurrent wheeze in pediatric age group? The answer is there is currently no standard definition for it. And what is very important is that some authors that may consider more than one episode of wheeze in the last 12 months can be considered as recurrent wheeze. And the European Respiratory Society Task Force for Preschool Wheezer in 2008, they are classifying the preschool wheezers into 2 main types, episodic wheezers and multiple trigger wheezers. Those episodic wheezers who wheeze only with viral infection with in-between attacks are completely free, and these are not asthmatic and not liable to take controller medications. And those with multiple triggering wheezers, in which we have multiple triggering factor for predisposition of wheeze, like exercise, exposure to cold, exposure to allergens, and the in-between attacks, some of these patients may develop cough or wheeze, and so they may develop asthma and they are subjected for receiving controller medications. However, this classification by any way is cancelled and not yet used for classifications. So we have a very important question. Children under 5 years, how many times they catch cold per year? The answer that most of the children experience between 4 to 7 colds per year, and even more than 10% may got more than 10 colds per year. And considering that each cold may be associated with bronchial hyperreactivity for a period of at least 2 or 3 weeks to recover from each cold, and may be associated with cough and wheeze during this period. However, this may be proof that bronchial hyperresponsiveness may occur or may prolong up to 5 to 11 weeks after each cold, especially in children below the age of 5 years. And this period of bronchial hyperreactivity may be prolonged more, especially in children who had atopic presentations or positive family history of atopy. And if you have recurrent colds the period of
It is an
bronchial
argument
hyperactivity.
that it is related to something that it may affect or it is important to many people. And usually in argument that there is no absolute right and there is no absolute wrong. Usually that there is an area that it is a common between both of us. So this could happen in many life activities, but especially it is happening in the medical field. In the medical field, maybe like the cancer treatment or management, you may have like many protocols or many other things. One of them is the pediatric asthma management, that there is many options that it is really controversial. So just for the history, what is meant by asthma, asthma is a Greek meaning for shortness of breath. And Sir William Osler in 1892, I mean, he was the father of the Western medicine. He was just defining the asthma as it is a distinct disease with a specific causes and consequences and the treatment. And he said that there is a paroxysmal dyspnea, peculiar character, and the patient supposed to be healthy in between the attacks. What was the treatment at that time? It was coffee, and I could tell you that coffee is a weak bronchodilator. The problem with the coffee that it is not having an acute onset. It would take some time. That's why it is very dangerous to depend on coffee treatment for someone having like bronchial asthma. The evolving history of the asthma, it started 1970s. What is was the pathophysiology of the asthma? It is only just a bronchospasm, and hence was the use of the short acting bronchodilators. Then in 90s, we started to understand more about the asthma, the pathophysiology, that there is an inflammation. And we have to guard against that inflammation. And that was the introduction of the anti-inflammatory, many anti-inflammatory medication and the drugs. Then we reached to the steroid. Then in 90s, we need to know that it is not just only an episode and just you are treating that episode and that's it. We came to know that there is a long-standing mechanism, that there is a remodeling, that it is happening in our bronchial tree, and we need to have like a controller. We have to have a long-standing management of the asthma. So the evolving treatment of or the options was there, as we just said, the SAPA, the corticosteroid, adding LAPA. What about like 2020? Let us see together. So just to refresh our mind, asthma, heterogeneous condition. The nature, inflammatory. It is not acute, it is a chronic. It is keep happening. And it is associated, this is the cardinal sign for asthma. Keep it in your mind. Wheeze, cough, shortness of breath, and chest tightness, and remodeling. It is keep happening. That's why you have to take an action regarding this modeling. The diagnosis of the asthma is really, it is a clinical diagnosis. You need to dig deep in a history. You need to have the symptoms and the signs to do the proper examination. If it is like above the spirometry result, above 5 years, it is applicable. Below 5 years, that you cannot do something like that. And to assess the response for the treatment. So it is a real puzzle for the diagnosis of the treatment, and there is no gold standard. You know why there is no gold standard? The problem that our decision, our clinical decision as a physician, usually it is vague, because sometimes what is the evidence for our decision? I will tell you what is happening with most of us. So it is dependent on the effective strategies that maybe that you did for a previous patient. Maybe that there is an advice by a mentor or by a colleague, or just an impression that you have got it from a random articles or abstract or symposium that you have attended. The problem that if you are considering these strategies as your evidence, that it would result in a variation in the decision. Even with a similar patient, this is a problem. And that's why we were looking for a systematic approach so we could have an appropriate strategy. So this supposed to be in common between all of us. We need to have an evidence-based medicine, the EPM. This is not the EPM. The EPM is the evidence-based medicine, not the expressed breast milk. So the evidence-based medicine that we need is relevant to our medical literature. But the problem not only just to be related to our medical, it is to our medical literature. Supposed not to be just only blind. It's supposed to answer the evidence-based medicine to answer a clinical question for a clinical situation. It is not just only that you are bringing for me an evidence and that's it. And you should take in consideration while you are putting this guidelines or the practical evidence that the cost the patient morals and beliefs, and the patient autonomy. This is very important. So we end up having like a consequence of steps to be formulated on a systematic way. Relying on what? On an evidence-based medicine. This is called the guidelines or the clinical guidelines. Why do we need a guidelines? Because this is the behavior or the performance of any reputable society. It is the standard of the practice, not the standard of the care. Standard of the care, okay, that you may bring like a very nice furniture, a very nice sofa, your reception is good. This is a standard of care. But standard of practice, this is related to what guidelines based on evidence-based medicine you are applying. The asthma guidelines, there is a lot of asthma guidelines that you could see, the New Zealand, the Canadian, the British, the Global Initiative for Asthma, the National Asthma Education, and the prevention. But today, I'm gonna focus on the Global Initiative for Asthma guidelines and the British guidelines. And this is the updates, a lot of updates that are happening on these guidelines. And just when they are comparing or whenever that you are choosing your guidelines specifically for asthma, you're supposed to choose what is the character or the item that we are comparing this asthma guidelines. So they are talking about the diagnosis and the evaluation, talking about the provocative factors, talking about the pharmacology, talking about the inhalation devices, talking about the exacerbation management. So all these, this is the items that you should, whenever that you are choosing a guidelines, you should keep it in your mind. And that's why we are talking about the British and guidelines, because most of them, or the both, they are talking about most of these items. What is the GINA guidelines? This is the Global Initiative for Asthma. So this is the symbolic for this the GINA guidelines. What is GINA? It is a partner organization in a program launched by the WHO, the Global Alliance Against Chronic Respiratory Disease, and the scientific committee is represented by adult and pediatric discipline, and from a diverse geographic region. That's why it is very important when you are choosing. It is not just only in Europe or in the States. It is also from our Middle East, and there is an asthma researcher plus a clinical practitioner like us. It is not just only a research. And the good thing about it that it is in a voluntary capacity. So it is not paid or funded. The point also that looking for what, Gina, for the asthma management, for the prevention, and looking for the level of the evidence. What is the level of the evidence that they are depending on, or what is symbolic for that, which is used in the GINA guidelines? If we said that evidence is A, so this is a randomized controlled trial, but you have a rich body of data. If you said that it is B, again, it is a randomized controlled trial, but it is a limited data. If you say that it is C, so this is an observational study, and D, this is the panel consensus judgment. So this is the evidence that we are having. And today, why I'm choosing a real case scenario? Because when you are looking for your teaching objectives, how you could memorize, what's the percentage that you could memorize for whatever a scientific activity that you attended? If you just only read, you will memorize just only 10%. If you hear, it is 20%. If you just, seeing like an images and some videos, it may reach about 30%. Then, if you are seeing like a demonstration that this is a 50%, or you are attending inside, while it is 70% if you participate in hands-on workshop. This is very important for us to know. That I would like you that if you could share with me the information during the for the chat box, so I could see how you are interacting with our case scenario for tonight. So this is the case scenario that we are having. This is Salim. He's 3 years old, brought to your clinic by his mother, suffering nighttime cough and wheezing 3-4 times a week. So 3-4 times a week over the last 2 weeks following an upper respiratory tract infection. The cough, the character of the cough, keeping him and the family awake the whole night. And there is a skin rashes. There is a past medical history that he is a preterm and there is no medication. From these, just I'm telling you, is that asthma? So the question that we need to know, do you think that Salim is having asthma? Yes, no, or maybe? I could see here in the chat. So maybe he is having asthma, and if it is not asthma, what it could be? Is it a viral induced wheeze? Is it inhaled foreign body? Is it lower respiratory tract, GERD, cystic fibrosis or any of the